Hello, everybody. This is Dr. Paul Sachs, and welcome to this quarterly brief. We're going to cover the last 3 months of 2022. And joining me today is Dr. Darcy Wooten, Associate Professor of Medicine and Infectious Diseases at UCSD. Darcy, welcome.
Thanks so much. So great to be here.
So let's start off by just talking about the IAS USA ART guidelines. Now, I am on this panel. And I want to say putting this together every couple of years is always great. Darcy, maybe you could tell me, was there anything in the guidelines you thought was notably different or controversial? I have some thoughts myself, but anything from your perspective?
Yeah, I think the few things that jumped out, I think really a strong emphasis on starting antiretroviral therapy earlier and as soon as possible, and even pushing the start point in the setting of opportunistic infections, which I thought was interesting. And I really liked the expanded and additional sections on substance use, older people living with HIV, things like that. So really enjoyed that aspect of the guidelines.
Thanks. I mean, one area that I worked on quite a bit and struggled with was management of treatment experienced patients, in particular those who have resistance. And the reason being is that, we've now seen a bunch of studies where people with virologic suppression can be switched to regimens with second generation integrase inhibitors. That's either dolutegravir or bictegravir, and plus 2 nucleosides, usually tenofovir plus FTC or 3TC, and maintain virologic suppression, regardless of really what their baseline genotype is. And I don't know, let me just ask you, if you're faced with a patient who has K65R and M184V in their historical genotype, but they are currently virologically suppressed, would you feel comfortable switching them to, say, dolutegravir FTC TAF or bictegravir FTC TAF?
I think so. I mean, it obviously depends on the individual context and how that patient's doing with adherence, but I think there's more and more data, as you mentioned, that was reviewed in the guidelines showing that this is an effective strategy. You want to monitor closely, of course, but with those second generation INSTIs, I think, and high barrier to resistance, some good data there showing that cautiously. Yeah. How about you?
Yeah, no, I'm comfortable making the switch from suppressed patients, people with virologic failure and that resistance pattern. I'm not quite there yet, although I do think the Nadia study gives us at least an opportunity to use that regimen. One other thing that, of course, was featured very prominently in this guideline was the use of cabotegravir rilpivirine, which we only briefly alluded to previously because it only got approved in early of 2021. So now we have much more experience with it. And you are, of course, at one of the biggest centers for cabotegravir in the country. So we're going to get to that in a minute. But while we're talking about long-acting antiretroviral therapy, I would like to bring up lenacapavir. And the reason I'm bringing it up in particular for this quarterly brief is because it was approved. Actually, it was approved first in Europe, but it got approved in the United States in late 2022. And it's the first capsid inhibitor, and it has this novel mechanism of action. And perhaps even more remarkable is it can be given twice yearly. And it is really long acting. It's given as a subcutaneous injection. And not surprisingly, based on the data that was submitted to the FDA for rapid approval, it was approved for heavily treatment experienced adults with multi-drug resistant HIV who are failing their current regimen due to resistance, intolerance, or safety considerations. Not a lot of people out there with this fitting this category. Don't you agree?
Agree. We actually have to have a conference once a month to sort of review all of these cases together as a group, because nobody, I think, individually in their practice at our center has, enough experience. And these cases are always tricky. And we've been talking about how and when we're going to use lenacapavir for some select patients.
Since I'm talking about long-acting therapy, I just want to put a pitch out for a supplement that just appeared in Clinical Infectious Diseases, a very fine journal that I'm extremely biased about. And it is a discussion about long-acting treatments in general, and not just for HIV, but also interestingly, tuberculosis, hepatitis C, hepatitis B, special populations such as women of childbearing age or women who are pregnant, children, use in low and middle income countries, the issue of these long-acting treatments and generics. I just think it was a nice collection from true leaders in this field of long-acting therapy, and not surprisingly, Charlie Flexner was front and center in assembling this. Just to put a pitch in there for that. So tell us some more about long-acting treatment. Darcy.
Yeah, well, and I was just going to tag on to that I really enjoyed that supplement. A number of the pieces talked about sort of rolling out long-acting injectable therapy and kind of implementation of this therapy, which has its challenges. And I think that was kind of one of the things I wanted to highlight in the carousel study, which was presented last quarter. So this was an implementation effectiveness study at 18 different sites throughout Europe, looking at different strategies to roll out long-acting injectable cabrolpivirine. And so the way that they did this study is they randomized each of the sites to either receive what they called the standard implementation intervention or the enhanced implementation intervention. And then they looked between these two groups at virologic outcomes at 12 months, and rates of virologic suppression were equal in the groups, about 87%. But there was a lot of missing data, about 26 people in each group. And the participants that were missing had mostly discontinued the study either because of non-injection site reaction adverse events or death unrelated to the medication. And so I think that's a fair number of missing people, which is, of course, I think concerning when we're talking about long-acting injectables because of this issue of the long tail, the long half-life, and the concern for resistance developing.
How has the experience been for you in the, quote, real world in terms of emergent resistance to this therapy?
Yeah, so we've, I think we have over 200 patients on long-acting injectable cabrolpivirine now, and it's very intensive in terms of both getting the insurance approvals for the medication, but then also just retention and making sure that people are within their window for getting their next injection. And so we've got a great team that really works on that. We have had 2 people who have quote unquote failed therapy to date so far, and these are in people who were not exactly under the indication to start this therapy. So people that weren't completely suppressed and really struggled with adherence, so not surprising. But it is something that we do see. And there are, obvious risk factors for virologic failure. And I think it's still unclear, how and when we can use this for people who are viremic, which is, a hot topic.
Definitely. But getting back to the experience in the clinical trials, there was this pooled analysis presented at Glasgow of Atlas and Flare and Atlas 2M, looking at the people in the study who basically were compliant with the therapy, were adherent to the therapy, and they got their injections on time, et cetera. And taking a look at the small number who experienced virologic failure with resistance and seeing what are the risk factors for this? The dominant thing is baseline rilpivirine-associated, resistance-associated mutations. That was the strongest predictor. In addition, HIV subtype A6A1. And there were also some concentrations of rilpivirine and cabotegravir that were predictive, but not as strongly as the other factors. I feel pretty strongly that people with a history of rilpivirine failure or even NNRTI failure with resistant mutations probably shouldn't get this treatment unless absolutely necessary. I don't know what you think, Dr. Wooten.
Yeah, I agree. Even if we don't necessarily see the resistance mutation that would predict resistance to rilpivirine, if you've got a history of antiretroviral therapy with virologic failure on NNRTIs where you're concerned that maybe that mutation is just hiding, I am very anxious about doing that. And I would say too, because of in other studies, BMI, particularly BMI over 35, makes me anxious. And so, you got to individualize it to the patient, of course, in terms of is this the right therapy for them or not? But that is predictive, and would like to just make sure that the patients moving forward with sort of informed decision making.
Sure, there was this dose response where, if you think about these factors, if you had more If you had none of the factors, nobody had confirmed virologic failure. So that's great. But if you had 3 or more factors, 20% had virologic failure with resistance. So, it's again small risk, but after having dolutegravir and bictegravir based regimens essentially have zero risk of resistance with good adherence, to see at least 1 to 2% of people who do get resistance on the treatment, especially integrase resistance, is something to keep an eye on. So I'm going to shift now to kind of the general ART, and there was a really, we thought we'd seen the last of the START study, but you have some other information on it, don't you?
Yeah, there was some long-term follow-up from the START study presented at IDWeek 2022. And as probably most people remember, the START study was a old school study from way back in the day, a randomized controlled trial of treatment-naive individuals. Everyone had a CD4 greater than 500, and they were randomized to either start therapy immediately or defer therapy until their CD4 cell count went less than 350. And what was presented more recently was looking at these two groups, everybody of whom was now on therapy, how they did over the longer time, following up to 2021. And what was presented at IDWeek and what we saw was that the excess risk for that primary outcome decreased in the deferred therapy arm, but it was still higher than the people who started therapy right away. So, more evidence and more reason to get people on therapy as soon as possible, because we do know that even though the risk goes down for this outcome, there are some long-term implications here. And I think really working to try and diagnose and treat people, because at least in my center, we see so many people presenting to care and getting diagnosed with very advanced disease. And we know that there's consequences to that.
So getting back to antiretroviral therapy, and an issue that is kind of become really a sort of a hot topic in all of our practices, is this business of ART and weight gain. And I was thrilled actually to be contacted by one of the investigators on the ADVANCE study. Remember, the ADVANCE study was a randomized clinical trial of TDF FTC efavirenz as the control versus TDF FTC dolutegravir as one experimental arm versus TAF FTC dolutegravir. So this follow-up trial switched everyone who was in that study to tenofovir lamivudine dolutegravir, or TLD, which is really kind of the default regimen globally right now, and then showed us in prospective fashion what happened to the weight on average at week 52. And the results are exactly as you would have predicted. If your baseline regimen was TDF-FTC dolutegravir, and you switch to TLD or TDF-3TC dolutegravir, your weight is the same. But if your baseline regimen is TDF-FTC efavirenz and you switch to TDF-3TC dolutegravir, your weight goes up by 3 kilograms on average median over 52 weeks. However, if you're on TAF-FTC dolutegravir and you switch to TDF-3TC dolutegravir, your weight goes down about 1.5 kilograms. I thought it was very interesting and very important. I wonder, in your clinical practice, whether you're using ART switches at all to manage weight issues.
It's such a great question. It comes up probably on a daily basis. And I will say I try to follow the guidelines and not switch, because that's the current guideline recommendation, is to not switch antiretroviral therapy solely for the purpose of trying to impact weight. I will say I do have a small number of patients who tell me they won't take their antiretroviral therapy unless I put them on something that is more likely to be weight neutral or help them to lose weight. And so in those cases, I have switched from TAF to TDF, for example. And it's just a question in my mind of, which one is worse, because we know that TDF compared to TAF is associated with weight loss, but or is more weight neutral, but is that healthy? Is that okay? And also, of course, the renal and bone toxicity that comes with TDF, is that better or worse than some of this weight gain that we see that is associated with TAF, but also, of course, second generation INSTI. So I don't know if that's the right thing to do, but that is what I have done. Again, trying to take a patient-centered approach.
I am now going to shift gears a bit, and I wanted to bring back an old friend who's going to be a new friend, and that is islatravir. Now, we've mentioned in these programs before that the investigations, the clinical trials on islatravir were halted because of observations of lymphopenia in people receiving the drug. And this included both the treatment studies and the prevention studies. But the good news is we actually heard that islatravir is coming back, that there have been enough investigations now on this adverse effect of the lymphocyte depletion. And we got some information at the Glasgow HIV conference on dose responses in the treatment-naive study. So they went back to their phase 2 dose-finding study, where patients were receiving islatravir plus doravirine, and then at the beginning of the study also with lamivudine. But the doses that were studied in this trial were 0.25 milligrams a day, tiny little dose, very potent drug, 0.75 milligrams per day, or 2.25 milligrams per day. They then followed it up by switching people to 0.75 milligrams from that original strategy, because that's the dose that they thought they were going to go forward with. And if the baseline was 2.25 milligrams per day and they switched to 0.75, lymphocytes increased. If the baseline was 0.25, the lymphocytes decreased. And if the baseline were 0.75, the lymphocytes were stable. So essentially what they've decided to do with this drug is give it as a once daily drug at 0.25 milligrams. And I just want to say that the 100% of people would be predicted to have the activity against the wild type virus at 0.25 milligrams by day 1 of dosing, which is really remarkable. But very encouragingly, in the steady state, after a variety of doses, 100% would also have activity against the M184V mutation. So these are encouraging data. They do support the fact that islatravir can go forward at this dose, and they have now resumed the doravirine islatravir clinical trials program. And they are going to use this dose. All right. Next, we are caring for an older patient population, which is one reason we worry about things like weight gain. But we also worry about cancer. Cancer is, of course, one of the leading causes of death of people in our country, and it's becoming one of the leading causes of death of people with HIV. What are you going to share with us?
Yeah, so there was a nice paper out in Lancet HIV that really gave us an update about lung cancer in people with HIV. We haven't had anything all that recent, and so this was a nice update there. It was a population-based registry study looking at lung cancer incidence among people with HIV between 2001 and 2016. So some good news from this study, lung cancer incidence has decreased about 6% per year during the study period. And the relative risk of lung cancer in people with HIV compared to those without has also declined during this time to just 1.5 times that of the general population. So that's great news. Of course, still more work to do. There still is a really large absolute excess risk, though, in some of the older age groups, particularly the 70 to 89-year-old age group. So important to be aware of and to take note and to monitor those older patients as well, and to continue to work on smoking cessation with every patient who's smoking.
Absolutely. Really critical, both for lung cancer and the cancer study that I'm going to highlight, which is basically looking at head and neck cancer in people who have HIV. Remember, head and neck cancer is, the risk factors are a combination of smoking, alcohol use, human papillomavirus. All three of these things are quite common in people with HIV. And this is a fairly large study that compared survival in people with HIV between 2002 and 2018. In people with HIV, 48 people with HIV to nearly 3,000 people without HIV. And it was quite striking. There was really a marked worse outcome in people with HIV. And I have to say, this is actually consistent with our experience. This is one of the more dreaded cancers that our patient population gets. And as I said, another good reason to quit smoking. I don't know what your experience is with this cancer in your center, but we work very closely with our head and neck cancer specialists because we have several patients who are followed there.
Yeah, fortunately, I don't have any patients in the recent past that have had this type of cancer, but definitely in our clinic. And I think in general, this is an area that maybe needs a little bit more investigation and in addition to not only just identifying, rates and risk factors, but also then, what can be done in terms of trying to improve these besides things like smoking cessation, of course, and reducing other risk factors that are known.
Going to actually continue on this theme of virally mediated potential cancers and switch now to hepatitis B. Take it away.
Yeah, so there are two studies focusing on HIV and hepatitis B that I wanted to highlight. The first is actually looking at prevention of hepatitis B, and this was presented at ID Week 2022. So this was the ACTG 5379 study, also known as the Beehive study. And this was a phase 3 open label trial, people with HIV who had not received the hepatitis B vaccine and were not immune. And so participants in the study received 3 doses of the newer form of the hepatitis B vaccine, Hep B CpG, which contains, of course, recombinant hepatitis B surface antigen, but also has an adjuvant that's a toll-like receptor 9 agonist. So great results from this study. 98.5% of people had a seroprotective response after 2 doses, and 100% of people had a seroprotective result after 3 doses. Titers were really high. 88% of people had a surface antibody greater than 1,000. Caveats for this study, though, the CD4 cell count in the population was pretty high, about 600. So unclear how this vaccine would do for people with lower CD4 cell counts. And then we're also pending the results of the second arm of the study, which is looking at people with HIV who had received the older form of the hepatitis B vaccine, but didn't have a seroprotective response, so-called hepatitis B vaccine non-responder. So that's a group that I'm really interested to see the results and see if this vaccine will be more effective.
Yeah, this is really impressive results, I got to say. I saw the response rates and it was like, wow, because we all know just how uncommon it is to get responses this high, not just in people with HIV, but anyone who undergoes Hep B vaccination as an older person. It's really, really, really impressive.
Yeah, so the other study I wanted to highlight was one that I was involved with. So for full disclosure, and this was a very small case series looking at the development of hepatitis B low-level viremia among people with HIV who are core antibody positive and then were being switched to long-acting injectable cabrylpivirine. So we looked at about the 149 patients in our clinic to date who had switched to long-acting cabrylpivirine. And of those, about 38 of them were core antibody positive, surface antigen negative. And none of those patients had occult hepatitis B by PCR analysis. And of the 38, 3 actually went on to develop low-level hepatitis B viremia about 1 to 3 months after switching to cabrylpivirine. So 2 of the patients opted to switch back to a regimen that contained tenofovir because of this. One of the patients opted to continue long-acting cabrylpivirine because he had really struggled with daily oral medication. And of note, this patient actually had a baseline surface antibody of greater than 100. Everybody did fine clinically. Nobody developed surface antigenemia. LFTs remained normal throughout. So I think hard to know what this means. Obviously, there's very, very small numbers.
I think it's a reminder also that we should do our best to update the immunization status of our patients before they switch to a non-tenofovir containing regimen. So let's wrap up now and discuss a bit about the opportunistic infection. I've noticed I called it an opportunistic infection, but it's really it does act that way in people with HIV. Tell us about Mpox.
Yeah, there are two updates on Mpox that I wanted to highlight. One was an MMWR report on a key series of patients with severe Mpox who were hospitalized. So this looked at patients who were hospitalized between August and October with severe Mpox. Not surprisingly, 82% had advanced HIV, most were male, 23% experiencing homelessness, and 68% were Black. And what struck me was how sick these patients were. So 30% were in the ICU, 21% died, and at least 5 of the deaths were attributable to Mpox. So all of the patients were treated with tecovirimat. Some also received vaccinia, IVIG, and cidofovir as well. So I think, these severe presentations are rare, but I think important to know about and that they can present in somewhat unusual ways. And what it seems to be the trend is that they're presenting in very immunosuppressed and vulnerable and marginalized patient populations.
Yeah, I mean, exactly. This virus in people with severe immunodeficiency is really nasty. Boy, this virus is not to be messed with if you have advanced HIV disease.
Yeah, well, and the good news is updates in terms of the vaccine and effectiveness there. So also from MMWR, there was a study showing real world data on how does the vaccine do in terms of reducing the risk of Mpox. So what they did was they looked at the incidence of Mpox among individuals who were unvaccinated but eligible for vaccine, and then compared that to the incidence among people who received either 1 dose or 2 doses of the modified vaccinia Jynneos vaccine. And the vaccine could have been given either subcutaneously or intradermally. And what they found was that the incidence was higher, as you would expect, 9.6 times higher in the unvaccinated individuals compared to those who had received 2 doses, and then 7.4 times higher compared to those who had received only 1 dose. But I think some remaining questions are, how long does this protection last? Are we going to need to do boosters or not? And then also just access. How do we get the vaccine to people who are indicated for the vaccine in this country and throughout the world who haven't been able to receive it yet?
Yeah. No, but this is overall in the context of good news. And I got to say, after watching us sort of bungle our way through the COVID-19 pandemic, to see really an impressive national and community response, an international and community response to Mpox, which now is, thank goodness, so rare. It was really gratifying. Well, Darcy, I want to thank you very much for helping us summarize the final quarter of 2022. I also want to thank you for showing us some very brightly colored Southern California garb, which contrasts with my boring white coat. And I hope you'll join us for a future quarterly brief sometime coming up.
Wonderful. Thank you. So always wonderful to be here. Thanks so much for having me.